You can make this clinic in your clinic. Anybody? If not, you can just put a no so that I know that you know you have not, and this is the first time you are listening or hearing about this material. Platelet rich fibrin. No. Sujay is saying no. No. Okay. Okay. Fine. So this is something new that you're going to study today. Okay. So what we'll do today is how I'm going to take this lecture is very simple. It'll be like I'll explain it to you like a small story. We'll go around the concept behind why we are using platelet rich fibrin, and then we'll come to platelet rich fibrin. Okay. Then we'll understand why we are using it. So if I suddenly talk about platelet rich fibrin, you guys won't have any clue why we are using it. Okay. So we'll go around the basic concepts once, and then we'll come back into this topic. Okay. I think we will start. We have around 11 people who have joined in. We will start. Okay. Okay. So before we go into this, I'm going to put a blank page and we are going to study a few things. So I'm going to ask you something. Just tell me what are the two main kind of periodontal diseases that you come across. Periodontal diseases. If anybody asks you, can you classify periodontal disease into two major types? What will you say it is? What will you say it is? Two major type of periodontal diseases. Everybody has to answer. Whoever is attending, whatever you know, you can write down. Okay. Nobody is judging you here. It's just for us to understand, and from here you learn more. So can you tell me what are the two main types of periodontal diseases that you commonly come across your clinic? Very good, Nupur. Very good. So that is your gingivitis. You have gingivitis and you have periodontitis. You have gingivitis and you have periodontitis. Excellent. So you have two main kind of periodontal diseases, gingivitis and periodontitis. Now, what do you mean by gingivitis? What do you mean by periodontitis? Very simple way of putting forward is, like if I draw a diagram here, this is your tooth. Okay. This is your alveolar bone here, and this is your gingiva right here. Okay, now what do you mean by gingivitis? Gingivitis is when there is inflammation within the gingiva. Inflammation within the gingiva, that is why we put it as itis. Itis means inflammation. So inflammation just pertaining to the gingival tissue alone, you call it as gingivitis. Okay, now once this inflammation progresses into the supporting periodontal tissues, that it moves into your alveolar bone, into your cementum, into your periodontal ligament, that is when you call it as periodontitis. I hope this two concept is clear. That means gingivitis means only inflammation of your gums in simple ways. Periodontitis when the inflammation from the gums has traveled and reached your bone, underlying alveolar bone, into the periodontal ligament and into the cementum. That is when you call it as periodontitis. What happens if you don't treat this for a long time? If you don't treat periodontitis for a long time, what will happen to that tooth? What will happen to this tooth? If you don't treat for a long time, what will happen to a tooth with periodontitis? Can anyone tell me? I'm drawing it here. So Sujay is saying recession. Can you put it mobility? Yes, good. The tooth will. Why did you say, Sunny? Why did you say the tooth becomes mobile? Why does it become mobile? What is the reason? What was supporting the tooth? What was supporting the tooth? The periodontium was supporting the tooth. Now what has happened? Yes, there is bone loss. See here where I've drawn the bone, and look at the level of the bone that I've drawn here. It's different. And the most important thing, yes, Sunny, excellent. It is loss of attachment. Okay, everywhere when you study about periodontitis or somebody talks, the main thing everybody will be loss of attachment. There is loss of attachment. What is this loss of attachment? This loss of attachment is nothing but, see, your gingiva or your junctional epithelium, which was attached here, now has moved down apically. Why did it move down? Because the PDL fibers which was here destroyed. The bone which was there destroyed. Everything is destroyed. So now the junctional epithelium will move down in an apical direction, resulting in pocket depth. resulting in defective bony contours, defective gingival contours. Now, what happens when the bony contours and gingival contours, or your gums are not normal, your bony architecture is abnormal? What happens to your daily routine? Something happens. What will it lead to? If the what will it, I understand mobility, everything. What is a major problem when your gingival contour is not right? When your alveolar bone contour is not right? What is a problem that will have to, what the patient will face on a day-to-day basis? On a day-to-day basis, just guess whatever you think will be the problem. Just think and just put it in the chat box. What do you think the problem will be? Anybody can tell what the problem will be? Traumatic occlusion, okay, so some kind of traumatic, but day to day this thing, whatever we do, what food, yes, excellent, not food impaction, not food lodgement, but where to put it in a simple way, you won't be able to cleanse your gingival contour in a normal way. It is positive architecture. Okay, your gums are put in such a way that whenever you eat any food, it is easily cleansed out of your oral cavity, from your teeth, from your gums. It does not stay. That is how God has given us our anatomy. But now we have teeth moving up and front, gums receding. All that will cause what? You, even if you brush properly, there will be food packing there. What will result with that? Slowly there will be plaque accumulation. Plaque will keep accumulating there. And what is the major problem if you have plaque? What is a major problem if you have plaque? If plaque is present, what is the biggest problem in having plaque in your oral cavity? This is the basic etiology behind all of this that we were talking about. Because plaque has, what does it have? It has bacteria. Yes, it has bacteria. It is very good. It has colonies of bacteria, different colonies of different type of bacteria, anaerobic bacteria, gram positive rods, gram negative rods, everything, whatever you could think about, it is there in the blood. So understood what has happened? Because of periodontitis, because of bone loss and all these things, your architecture has changed in such a way that now even after you brush or even after you rinse your mouth, food is not cleansed out properly, resulting in what? More plaque accumulation, more bacteria, more inflammation, more bone loss, more loss of attachment. Finally, if you don't treatment, the outcome is like you guys said, bone tooth loss from that side. The tooth will become loose, 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 and finally it will come off. Okay, so now as a clinician or as a periodontist, what is your aim? Your aim is to make sure that the loss of attachment is stopped. There is, or you restrict the amount of loss of attachment that is going to happen in the future. What has happened, but at least to stop in the future. How do you do that? What is the first step that you have to take to make sure that this does not occur more? How do you start this process? When a patient comes to you, when you feel that the patient has periodontitis, what are the initial steps that you take? Very good. Yes, that is initial steps is about oral hygiene instructions. You tell the patient about the importance of oral hygiene, because already now we understood, because of bone loss, because of irregular architecture of gum, already plaque is accumulating, more calculus. Okay, so the patient now has given up, is not brushing properly. Even after brushing, this problem is there. So now what do you do? First and foremost, you give good oral hygiene instruction. Then, like all of you said, you have to remove the foci. You have to remove the foci. What was a foci? Plaque. What was a foci? Plaque. Okay, so you have to remove that. So how do you do? What is the most common way of plaque removal? What is the most common way of plaque removal? Can I have the answers here? Most common way of plaque removal. How do you remove plaque? Most common way of plaque removal. What is the most common? Okay. Okay, one answer has come. Second answer has come. Dentifrices. Very good. Very good. So, see, plaque is something which you can remove using what? A toothbrush. You brushing, excellent, Nupur. Yes. Proper brushing. That is where it has to start. Proper brushing is where, if you see the chapter of plaque control, what you study in that, think like that. Don't immediately go and say scaling. Scaling is actually not meant for plaque removal. You will remove plaque along with that. But plaque removal actually should start at home with proper brushing, interdental aids, flossing, water picks, all those things you should use. Okay, so brushing, that is how you remove plaque. If you get a question, it's actually not scaling. It is actually brushing. Okay. Then plaque, if it stays for a long period of time, it gets calcified. It gets calcified. And then what you get? C for calculus. You will have calcified plaque, which becomes, you call it as calculus. Now, will calculus go off with brushing? It will not go off. That is when you have to implement scaling and root planing, and because you have supra and subgingival. So you do scaling, you do supragingival scaling, you do subgingival scaling, and you clean off. Why are you removing calculus? Does calculus have bacteria in them? No. Calculus does not have any bacteria. But calculus is a rough structure which will aid more plaque accumulation. If you have calculus in your mouth, that means you have more irregular surfaces in your mouth, meaning more plaque accumulation, meaning more inflammation, meaning more loss. So that is why we are scaling and removing all the calculus. As such, calculus is not causing us any damage. Okay, but it has irregular surface causing more plaque accumulation. So you do scaling and root planing, and you remove the etiology. Etiology, like we studied, is the plaque or the bacteria. You remove that. Now, once all the phase one, your cleaning and everything is done, then you decide what to do. The surgery, the surgical part. The surgical part is divided into two phases. You can have resective surgery and you can have regenerative surgery. From the terminology itself, you will understand what do you mean by resective surgery. You're going to chop it off or you're going to cut it off. Okay, so you have irregular gingival contours, big bulbous gingival structures, fibrotic structures. Of course, it will accumulate plaque there, and you cannot do anything else. You cannot do anything. You have to cut it off. That is gingivectomy. We remove the gingiva. Same way for the bone. There are irregular bony contours, and you feel that they are horizontal pattern of. We'll study all this just to understand. You cannot do any regenerative procedure. You reshape the bone. That is again by resective. You cut it and reshape the bone to get a positive architecture, to get an architecture which will be self-cleansing in nature, or the patient can nicely clean and maintain. Okay, so that is a resective side. Now, in some defects, what happens? You will have something known as vertical kind of defects, where it will be like a box. The bony defect will be like a box, like this. Okay, so in this, the graft can be contained, or you can understand that, okay, here, not only can I correct the architecture, I can regenerate something. I can gain some attachment. We already had loss of attachment. Here, you're trying to gain that attachment. And those procedures are known as regenerative surgeries. Okay, now today's topic, that is PRF. PRF is one of the component that we use in regenerative. That means we are trying to regrow. We are trying to, can't see the screen. Is it not clear to everybody? All of you can see the screen, or is it not visible? What I am drawing and writing, you cannot see? Okay, it is visible. So just refresh your screen. Those who said cannot, please refresh your screen. Okay. So PRF now you understood what we are talking about. What we are going to study today is about PRF, and where do we use it? We use it in regenerative surgery. Okay, not anything else. We use it in regenerative surgery. Okay, I hope till here it is clear. We are now come to our topic, that is PRF. So we studied what gingivitis is, what everything in a short. Okay, what gingivitis is, what periodontitis is, what it causes, how do you treat it, and then finally how do you finish it, or what is the final treatment, either resective or regenerative. In regenerative, we are gonna see PRF. Okay, so now we are gonna talk about regenerative surgery. So what is regenerative surgery? Regenerative surgery is defined as restoration of lost periodontium. Restoration of lost periodontium, which includes formation of new alveolar bone. We saw bone level going down. So we are expecting new alveolar bone to be formed, new cementum, and functionally oriented periodontal ligament, resulting in new attachment. So new attachments are going to come into the root and into the cementum, and the level of attachment is going to increase. So that is our aim of periodontal regeneration. Okay. Okay, so how does regeneration occur? The first thing, you have to eliminate the cause. We understood how to eliminate it. Okay, by scaling, root planing, all those things, you can eliminate the cause. Then for the regeneration to occur, what is the thing? We are trying to regenerate cementum, trying to regenerate periodontal ligament fibers and alveolar bones. So you need the cells, that specific cells of those regions. So you need proper active cells and matrices and mediators required for this to occur, and you need a good healing environment. So when all these factors are combined together, elimination of cause, there should not be any more bacteria there. There should be presence of your cementoblast, osteoblast, all these required to deposit new cementum, new periodontal ligament fibers, and new alveolar bone. And during this time, the heal to boost the regeneration, the healing environment should be kept nice. Okay, so that is how regeneration occurs. Okay. Now, what are the challenges in regeneration? It's not like where you have a skin cut and you have new skin growing there. In oral cavity, imagine, first of all, every day you are eating everything through this. And then it's not just one tissue you're trying to regenerate. You have to regenerate bone. You have to regenerate cementum, periodontal ligament. So you have multiple tissues that has to be formed in a proper manner. You cannot just have bone forming. Then it will go into ankylosis. You cannot have just epithelium growing. That will form in long junctional epithelium. There are a lot of challenges. So every single tissue has to form at the right pace, at the right time, and in the right amount. Very important. Now to achieve this, actually you have to, it has to be just like your embryogenesis and morphogenesis. That initial stage of your growth or your development has to be recreated inside your oral cavity. And many times what happens, there is incomplete removal of pathogenic factors. You are not properly able to remove pathogenic factors from that site before you go for periodontal regeneration. Okay, so these are the challenges that you face. Now, what are the components? What all you require for regeneration to occur? What all you need at that site when you have a defect? What all you need? Okay, so let me draw here. This is the tooth that we are talking about. This is the bone defect here, like this. Okay, vertical kind of bone defect. So what all should we provide for us to gain attachment, okay, at least from here, for us to gain attachment till here, what all? First thing that you need is a scaffold. Scaffold is nothing like a bed. Imagine to be a bed onto which your cells can come and lie down. Cells can come and lie down and will lay down bone or PDL fibers or cement. So scaffold is nothing but it's a bed into which all the cells and signaling molecules can come. Now, how do you provide scaffold? Scaffold, you can actually keep collagen membrane in this defect, or you place bone particles, bone graft you place. Okay, if you place bone graft, they act as scaffold. Now, once you place scaffold is done, the second important part is cells. The cells should be present. What all cells? Osteoblast for bone, cementoblast for cementum, and fibroblast for PDL. They should be present. So once you place graft, if it is an autogeneous graft, these grafts have viable cells that can produce these cells. Otherwise, these signaling molecules can cause the other cells in that area, other pluripotent stem cells, to get converted into osteoblast, cementoblast, or fibroblast. Okay, so you have scaffold now, you have cells. Both of this can come from the bone graft. And finally, you have signaling molecules. Very important. What are these signaling molecules? These are your growth factors or adhesion molecules or differentiation. Now, these signaling molecules, what do? They give out signals to the surrounding cells. Okay, so when you place these signaling molecules there, whatever pluripotent stem cells are there or undifferentiated mesenchymal cells are there, these signaling molecules will go and tell them, okay, it is time for you to convert into osteoblast or cementoblast or fibroblast and lay down bone. So when you place all this here, finally what happens? The bone, we expect new cementum, new alveolar bone, and new PDL to form, resulting in gain in attachment. Whatever attachment loss, from here, the epithelium will attach back at this level. You would have got this much of attachment you has gained. Normally, before it was still here, now your level is here. So this much is the gain of attachment. Understood? You are regenerating new tissues so that whatever defect was created, you are covering it up with the new bone, new cementum, and new alveolar bone. Okay, PDL. Now, the signaling molecules out of that, this growth factor is very important. And today what we are studying, this PRF, platelet rich fibrin, what it does, it is a type of structure which gives out growth factors, or it provides growth factors. Okay, so if somebody asks you what provides act as a scaffold, you can say grafts, bone grafts. What provides cells at the site of regeneration? It can be your autogenous graft, that is graft that you take from your oral cavity itself. For example, from your edentulous area, you cut bone and put it there. They are autografts and they have their own viable cells. And if somebody asks you, what are the signaling molecules that you can provide at that site, or how do you provide signaling molecule? One of the way is by using PRF. So I hope you understood why we are using PRF. Okay, they are actually providing signaling molecules for your regeneration to occur. Okay, so that is the whole concept behind this. Okay, now since this is clear, now we will move on to what growth factors and what is a PRF. Growth factor is nothing but family of polypeptide biological mediators which can modulate cell responses such as cell adhesion, proliferation, chemotaxis, and differentiation. What are the different types of factors that we have? You would have learned this: platelet derived growth factor, vascular endothelial growth factor, epidermal growth factor, fibroblast growth factor, and insulin family growth factor. Out of this, the PRF provides mostly your platelet derived growth factor, vascular endothelial growth factor. They will release all these factors into the site. Okay, they will release all these factors into the site. Okay, now let's see what is platelet concentrate. So platelet concentrate is a bioactive agent that promote and accelerate healing, understand, healing, regulate inflammation, and improve regeneration. So based on the leukocyte content and the fibrin structure, platelet concentration can be classified into 4. Okay, so this platelet concentration, this two is, you can put it as one. They are actually PRP, that is your platelet rich plasma. Platelet rich plasma. And then you have your PRF, that is your platelet rich fibrin. This is the first generation. If you want another classification, you can say this is the first generation platelet concentrate, and PRF is your second generation platelet concentrate. First generation is PRP and the second generation is PRF. Very simple. Okay, so one classification is first generation, second generation platelet concentrate. First generation is PRP, second generation is PRF. The other one is this can be subclassified as pure platelet rich plasma or PPRP, leukocyte platelet rich plasma, that is LPRP, these two. Okay, for PRF also, you have pure PRF and leukocyte rich PRF. Okay, that is based on the amount of leukocyte content which is there. In leukocyte rich, the concentration of leukocyte will be more than 75%. Okay, high amount of leukocytes. Leukocytes are very important during healing and for release of growth factors. Okay, so I hope this is clear. What are platelet concentrate, what are the generations, and what is PRP and PRF. PRP is first generation, PRF is second generation. Okay, when we go into details of this, I will tell you the difference and all of both. Okay, so now coming to PRF, our topic. Okay, now we are coming to our topic. Okay, so what is PRF? PRF is a second generation platelet concentrate. It was introduced by Chowkran et al. Very important MCQ question. Okay, who introduced PRF? Chowkran et al. Or Chowkran and co-workers in 2001. Okay, now what are the advantage of PRP as compared to PRP? Okay, advantage of PRF as compared to PRP. Okay, now this PRP, the problem is it's a very technique sensitive procedure. It has multiple steps and you have to use anti-clotting or jellifying agents in PRP. Whereas PRF, you don't require any of that. So no need of any clotting or jellifying agent. It has a dense and 3D architecture, very important. High concentration of platelets and leukocyte. It's a very simple procedure, very cheap. It is less expensive and less risky. Okay, so that is a basic difference between PRP and first generation and second generation. This thing. Okay. Now we'll study how this PRF. Like I said, I asked you, many of you, do you make it in your clinic? Last week only we had a case and we did it in our surgery. In my own surgery, we can make this. Okay, we learned that. So just before that, let's see what are the components. So like PRF, platelet rich fibrin, very simple from the terminology. It has high concentration of platelets, then all the growth factors that I talked about, and high concentration of leukocytes. So these are the basic components within a PRF. Now, how do you make this in your clinic? Very simple. All you need to have is your test tubes and a good centrifuge machine, a tabletop centrifuge. Now, like I said, you'd open a flap, everything is ready. You've cleaned out the defect and everything is ready. Now, you place the graft and now you're looking for a, what all do you need for regeneration? You need cells, you need a scaffold, and finally you need growth factors there. So to provide growth factors, we'll make the PRF. So once you place the graft and everything, what you do is from the patient's hand, you take 10 ml of blood. From the patient's hand, you take 10 ml of blood. You do a venipuncture and take 10 ml of blood. Take that 10 ml of blood, pour it into a glass test tube, and then put it in the centrifuge. Centrifuge it for 300 for 10 to 12 minutes at 300 rpm. Okay, somewhere between, you can say 2700, because some textbooks give 2700. So between 2700 to 3000 rpm, you centrifuge it for 10 to 12 minutes. Once you finish the centrifuge, what will happen is that this is how your test tube will look. See this? This is how. This will get, the whole blood will get divided into 3 layers. The top layer will be a thin, like liquid like thing, which is your platelet poor plasma. Okay, it will just flow out. Then you have this thick layer. Can you see this thick layer? That is your PRF. And then you have this red layer. This is all the RBCs. Heavy RBC has the maximum weight, so they all settle down. So you have poor plasma at the top, poor platelet plasma at the top. Then you have PRF in the center, and then you have the RBC. Why I am showing you this picture? Nowadays, there are a lot of MCQs on picture based. They can show you a test tube and then they can ask you these 3 layers of the centrifuge after your PRF spin. So you should know the topmost layer is your platelet poor plasma, PPP, platelet poor plasma, topmost layer. The central layer is your PRF, and the bottom layer is your heavy RBCs which have settled down. Okay, now what you do, you take a plier and you pinch it out like this. See, you can pinch it out like this, and you will get the PRF with little bit of RBCs at the bottom. This normally with a scissor, we cut it out like this, and you get this whole PRF like this. This PRF can be used in different, it can be used as a clot, as this PRF clot can be directly put into the defect. It can be used as a membrane for guided tissue regeneration. It can be used as a membrane for guided tissue regeneration. This can be now mixed with bone graft and then placed into the defect. So there are a lot of application of PRF. Why this is important? Again, you should understand, because it has all the growth factors loaded inside it, and you're putting it at the defect, expecting all this growth factor to act magic there. Okay, so this is about your PRF, how it is made, what are the layers, and what it contains. See, once you get the final PRF, mostly you have high concentration of platelets, leukocytes, and your growth factors. You should know the spin time and the how much RPM is used to spin the PRF. Most questions are from this area. Okay, I hope this is clear. Is it clear till now? Is it clear till now for everybody? Can I move on to the last few slides? Is it clear for everybody what PRF is, why we are using it, where do we use it, what are its components? Okay, very good. So you can make this in your clinic when you're doing, you know what is another important application of PRF? You have done a third molar extraction, a difficult third molar extraction. You have cut the bone, everything. Put the PRF into that socket, clean it nicely, put the PRF into that socket, suture and see. The post-operative results, the post-operative discomfort, pain, everything of this patient will come down. Okay, it's a very cheap material. You can charge the patient, but actually, do you have any cost? You have cost of only 5,000 rupees of the centrifuge, one-time investment. That's it. And you can have such a nutritious stuff being put into the defect for the bone to grow. And it has a very good soft tissue healing property also. So in all ways, it's an excellent material that will help in healing. Okay, so third molar extraction sockets or even any extraction socket where you had very difficult cutting and you have chopped off the gingiva, you have cut the bone a lot, try using this. You will have excellent post-operative pain discomfort, reduces a lot for the patient. Okay. Okay, now coming to certain clinical cases that I've done, and I'm showing you the pictures just so that you get an idea of how what we do. Okay, so this is our first case that we did. If you can see the defect here, okay, you can see the defect inside. It's a vertical defect. Okay, see my probe going. It's a UNC 15 probe going way into the defect. Almost 3/4 of the probe has gone inside. So that is a vertical kind, or it's a contained defect. Wall on all sides, and you have a nice defect where you can pack everything. So what we did is that after scaling and root planing and removing all the granulation tissue from the defect, can you see these white dots here? That site is filled with graft first, and we have done a what this thing you see is pre-suturing. We suture prior to placing the graft and PRF membrane, because if you place everything and try to take the needle through it, it will displace the graft and the membrane or the PRF. So we pre-suture. All we now need to do is tie it once we place everything. So the graft is placed inside, and then can you see this membrane that has been, that white thing that has been placed inside? On top of the graft, we are packing the PRF into it. We are packing the PRF. So what did we provide? We provide the cells plus scaffold here for regeneration. Here we are providing the growth factor. Okay, so all the three components, cells, scaffold, and growth factor. And another important thing, adequate blood supply. The site should get adequate blood supply. That is the center of everything. Okay, so all these factors we have provided. We have provided cells, scaffold, we have provided the growth factor, and this PRF will there, and then we will suture it completely. And initially I said during regeneration, important is the site should not be disturbed. It should have a, what do you say, a proper healing time for it. So normally what we do, we give periodontal dressing so that the site is not disturbed. Okay, this x-rays is not that clear, but actually you can see the amount of bone fill that has occurred in both as compared to the defect. You can see a black triangle here, both these areas. Okay, so that has been filled completely with the bone. After 8 to 12 months is actually when you can see the difference. Okay. Okay, so that's the first case where we have used graft. Another case in the anterior region. See the canine here, after we opened up, such a big defect. This is like you can say a 2-wall defect. 2 walls are remaining. Okay, sorry. 2-wall defect. So again, in the defect, what we have done, cleaned and curated the area nicely. Here, can you see the granules put? These are bone graft. We have put bone graft on top of that. See, the PRF is being placed and then sutured, pack given. Same concept. You are providing cells, you're providing scaffold, and you're providing growth factors. And you're expecting the bone to grow back there. Okay, so that you get gain of attachment. Okay, again, you can see my whole probe going completely inside. Okay. And then it's another case, a little complicated case where you have a bifurcated, you can see the bifurcation here. Can you see the premolar has split? It has premolar has 2 roots. The first premolar has 2 roots. And there was a severe bone defect. Can you see the defect here like this? A severe bone defect all around that area you have. They have big defect here, a big defect here like this. Okay, so the whole area is cleaned. Again, can you see the graft that has been put here? The graft has been placed all over. Everywhere the graft has been placed. Then here what we did is that we placed, the PRF has been placed inside, and the rest of the PRF, we made it into a membrane and we covered, because here, because of the bifurcation, we expected that there can be some kind of recession. So what we did, we use a membrane, we use the PRF as a membrane. I said the multiple applications of PRF. So along with the packing into the site, we used it as a membrane. See, covered the whole root area completely. And then on top of that, we sutured the flap. Okay, and excellent. We had excellent post-operative result for this case also. The patient is extremely happy, and even good gain of attachment we had got in this case. Okay, so this is how we use PRF and in different defects, in bone defects that you use in combination with graft. Because we are not only we are thinking about just bone growing, we are thinking about regeneration, everything growing back in that site. Okay, is it clear? Did you get an idea about how we are using PRF? Where do we place it in combination with what? Why we are combining? Everything is important. Okay. Okay. So now what we'll do is that we'll discuss 2-3 questions associated to PRF. Okay. A few MCQ questions related to PRF. Okay. Question number 1. You can give your answer in the chat box. All those who have listened, just give your answer in the chat box. Platelet rich fibrin first developed by. Platelet rich fibrin first developed by. Only 2 of you have answered. There are 20 of you. No, some more answers can come in. Yeah, very good. It is your the first the person, that is Joseph Chowkran in 2001. It has been an MCQ question that has been asked. Okay, so you should be aware of this. Okay, very good. Question number 2. PRF is first generation platelet concentration, second generation, third generation. Yes, it is a second generation platelet concentrate. Okay, very good. So this is something new. The whole topic is new for most of you guys. So something new you have learned today and you are able to answer it. Very good. Advantage of PRF over PRP. Advantage of PRF over PRP. Okay, this is second generation. This is your first generation. What all did we talk about? We said that it does not require any anti-clotting factors like thrombin. We don't use that. No second spin. We understood there's only one spin at what? 2000 to 3000 RPM for around 10 to 12 minutes. Okay, and it is very cheap. It is not expensive. So your answer is all of the above. Okay, very good. All of you have got it right. Very nice. Okay. Last one. What is the limitation of PRF? Okay. What is the limitation of PRF? What is the limitation of PRF? Okay. Very good. Very good. All of you are thinking. Many of you are coming with multiple answers. Okay. So first, let's go by one. Okay. When you are question, when you reach and when you think you don't know the exact answer, go one option at a time. The first option, volume is limited. What do you mean by volume is limited? That means, can you take 20-30 ml of blood, keep poking the patient and take multiple pokes and keep taking the blood out of the patient? No. You can take it once. Maximum you can take is in one. You can use a 10 ml syringe and maximum you can get is around 10 ml of blood. Okay. So one thing is that volume is limited. You cannot take large quantities and use it for larger quantities. So first thing is volume is limited. Second one, quick handling. Okay, ideally they say within 60 seconds, you take the blood, you should immediately put it in a centrifuge. Otherwise, you're not using any anticoagulant or anything in this because it's a second generation. So if you keep it for a longer time, what will happen to that blood inside the glass tube? What will happen to the blood if you don't handle it quickly? What will happen to the blood? If you wait for 5 minutes and then you plan to put it into a centrifuge, what will happen to blood when it's kept outside your body? Very simple. Not even one of you is answering. Come on. What will happen to the blood if it? Yes, it will clot. It will clot. The whole thing is spoiled. So quick handling is extremely important. So that is again a limitation. You cannot hold the blood for a long period of time. So everything has to be arranged properly. You cannot take the blood once you have opened the flap. By then the blood will clot. So you have to wait for the correct time and it has to be handled quickly. It's not like your bone graft that you get in a box. You can take it out anytime you want. You don't need any quick handling. Nothing will happen to the bone graft. But here you need to have quick handling is required. Otherwise it will clot out and it will go. Okay. So already now we have got 2 correct answers. Is there any doubt now which will be the answer? Yes, your answer will be all of the above. Again, storage for no longer periods are not feasible. You understood why? Once you start using it, if you don't use a membrane within some time, it will all shrink. All the fluid, all the growth factors will go out of it. It will be destroyed. Okay, so that is also a limitation. So volume is a limitation. You have to handle it quickly and you cannot storage for long periods of time. Okay, storage for long periods are not feasible. So all these are small limitations of PRF. But we can bypass all this and do our procedures if we plan everything at the right time. Okay, so just to understand the limitation, this question is put forward. Okay, so that you know what the limitation. And now with this question, what did you do? You have to eliminate one option at a time. If you have two doubts in your, if both of them are right, then you don't have, you look for all of the above answer and you mark all of the above. Okay, so that is the limitations of PRF. Okay, so with this, we come to the end of the MCQs and today's session. Okay, so if you have any doubts now, you can ask me anything related to this. If you have any doubts, you can ask me anything clinically related or anything related to, or how the most of the sessions will be like this. Okay, you will have question and answer discussion, and the most important theory we'll give you. Most of our videos are also like this. Bone also, yes, bone will also grow. That is the whole point. That is why we said osteoblast, cementoblast, and fibroblast. We need PDL, cementum, and alveolar bone. Okay. That is why we are placing the bone graft there. The whole point of bone graft is we are expecting bone to regrow there. Okay. Any other doubts? If you have any other doubts, anybody, you can ask. Don't be shy. This next 1 year is the time for you to ask questions. It's not to keep quiet, it is for you to ask questions. The more you ask, then more you learn. The more you keep quiet, the less you learn. Okay, so whenever you have doubts, clear it then and there. Do not wait. Do not think that I will read it somewhere else. If somebody can help you out, ask it and clear it out. Okay, is it okay for everybody? Okay, can I get a thumbs up if it is okay? Yes, at least a yes. Okay, okay, okay then. So thank you so much. Thank you so much. Okay, we'll all meet for the contact classes now. Okay, sorry, your direct classes through Zoom. Okay, whenever your schedule comes, all those who are joining in, we'll meet you for your classes. Okay, suturing will be done after pack. Sujay, how can you suture after the pack is done? How will you suture after the pack? Suturing has to be done before that. The flap will be placed, it will be closed, and the pack is just to protect that area. The whole point of periodontal pack is not, it does not do anything, no other advantage. It just protects, it just provides a protection in that area so that you don't have any trauma or your brush doesn't hit that area. It's nice, just like how you fracture your hand, you put it in a cast, no? Same thing, the same role of the cast, the pack also plays to protect that area from any unwanted movements. That all. Yes, the pack will be dislodged. If it is not put properly, it can get dislodged. Otherwise, most of the time, the pack stays there. Because what we do is that we put the pack on the buccal side and on the palatal side, and then you connect them through the interdental areas, wherever it is possible, or through areas you connect them and keep. So normally it stays there. And you ask the patient not to brush there. Patient does not brush. You give the mouthwash. For that area, you use the mouthwash. If there is gingival recession due to ortho treatment, can it be treated? It depends on what type of gingival recession it is, what grade. See, you cannot do any, like I said, we talked about regeneration. You cannot do regeneration on a horizontal pattern of bone growth. You cannot. There, you have a procedure is different. The same way, we have to see what kind of recession it is, how much the recession has proceeded, whether it has gone beyond mucogingival junction, where there are any other dehiscence fenestration. We have to assess all that. If it is a 1 or 2 mm, yes, for sure you can correct it. You don't have to worry about it. It can be easy. A coronally positioned flap will itself do that procedure. But if it is a big recession, lot of millimeters loss, lot of bone loss beyond mucogingival junction, no attached gingiva, surrounding areas very poor hygiene, then it is a difficult case. Okay, that has to be assessed, and then we will study all this. What recession classification? How do we go about everything? Success rate of PRF is excellent. From my PG time, I am doing that. From my PG, at least you can say that post-operative pain, discomfort, everything comes down for the patient. Post-operative soft tissue healing, it's excellent. Okay, that is it. See, as a clinician, you can never judge whether the bone is formed there to what extent. You are not opening up that site and looking again. All you can do is that probe again, so that your before the pocket depth was 10, now it is 5. So there is some kind of gain of attachment. You cannot exactly tell whether regeneration has occurred, whether the PDL formed, cementum formed, bone formed. You cannot tell that. For that, you need an histological evaluation. You cannot do a histological evaluation on a live patient. Never possible. So how do we evaluate whether regeneration has occurred? Probing depth, attachment level, you measure it, radiographs. This is the only way. With that, we can say that we have gained attachment. Again, we cannot exactly say whether PDL was formed, whether cementum was formed. No, some fill has come there. Some bony fill has come there. That's it. We have gained attachment there. Okay. So if you are saying success rate as such, yes, PRF is very successful in post-operative healing. The success is very good. Even bone fill also, you get a good bone fill with it. That's why I said after post-extraction, you can use it. Patient will have a much comfortable healing phase during that time. Okay. Okay. I think it is clear for everybody. No more questions, right? No more questions? Okay. So thank you so much. I will see you all for our classes now. Okay, study well. Yes, post-extraction, you can use it. Huh? Post-extraction, you can use it. If you have a centrifuge machine, you can use it. Okay. You can buy one. It's only around 5,000, 6,000 rupees. Okay. So study well, start studying, start focusing well, and I'll see you all for the classes. Huh? Okay. Take care. Yeah. Thank you. Thank you so much, Alina. Thank you. Thank you. Yeah. Bye-bye.